Thank you for being here. My name is Megan Phelps. I am a third-year resident at Full Circle Health, or previously FMRI, about to graduate in 2 weeks. I'm going to an OB fellowship next year, and then today I'm giving a talk on liver disease and pregnancy in the reproductive years. I hope that whether you are someone who doesn't do any prenatal or obstetric care at all, or whether you're someone who just does prenatal care, or whether you're someone who does deliveries or C-sections, that you could find pearls from this talk. I do not have any financial interests. And then our objectives are to first review the preconception, counseling, and contraceptive management in reproductive age patients with chronic liver disease, to outline current evidence-based guidelines on the management of gestational liver disease, as well as acute and/or chronic liver disease that can co-occur in pregnancy, and then also to recognize the role of a family physician as part of a multidisciplinary team. And then here's our outline. First, we'll talk about the two different classifications of liver disease and the physiologic changes of pregnancy. Next, we'll move into contraceptive considerations in patients with chronic liver disease, female patients or patients with a uterus. Then after that, we'll move into discussion of acute and chronic liver disease that can co-occur in pregnancy, followed by gestational liver disease. And then we'll talk a little bit about social determinants of health, the role of a multidisciplinary team in treatment of these conditions. So first, overall, there's two different classifications of liver disease. Here's a picture by Netter. And so there are acute and chronic liver diseases that can co-occur in pregnancy, and that can happen to anyone. And so those are down here, incidental, and the ones that I will speak about is hepatitis C or viral hepatitis, cirrhosis, and then MAFLD or NAFLD. And then there are gestational liver diseases that happen only in pregnancy or are caused by pregnancy. So here, eclampsia, fatty liver. So we'll talk about the hypertensive diseases of pregnancy, cholestasis, and acute fatty liver of pregnancy. Here is just a little bit about the physiologic changes of pregnancy. And so first I wanted to review the changes that occur in pregnant patients without any sort of liver disease. You have an increased blood volume so that you can get more blood to the placenta and to the fetus. You have increased splanchnic vasodilation, decreased systemic vascular resistance and blood pressure. And then you have increased collaterals and increased portal flow. Pregnancy, even in patients without chronic liver disease, has been shown to increase the size of non-clinically significant esophageal varices just because of some of these changes. We also know that pregnancy is a high estrogen state, so you can see the little spider angiomatas as well. But when you have pregnancy and you have someone with chronic liver disease, they can kind of compound on each other. And so if they have chronic liver disease, then you can have increased clinical consequences. Specifically, you could have increased size of varices or risk of bleeding, ascites, hepatic encephalopathy. Now we'll talk about contraceptive considerations for patients with chronic liver disease. And so I broke this down into 4 categories. One is help getting pregnant. And so sometimes, not always, these patients, because of the altered estrogen metabolism by the liver and or disruption of their HPA axis, they can have trouble with fertility, amenorrhea, and ovulation. That's not something I'll focus on in this talk, but it's just something to be aware of if you're treating this population. The second would be help not getting pregnant. So we'll talk a little bit about contraception and what's safe, etc. You'll want to keep in mind any medication changes that the patient will need to come off of or be changed because of possible teratogenic effects. And then I think, again, even if you're someone who doesn't do any obstetric care at all, knowing the risks to the baby and to the mom so that you can have a discussion with the patient about that. For contraception, like everything else, you want to use shared decision making and kind of figure out the goals of the patient, even in spite of these recommendations. Kind of a harder rule would be avoiding estrogen containing contraceptive options in patients with decompensated cirrhosis. There's a lot less risk with progesterone containing or hormone free options. This slide is from the AASLD 2021 practice guidance. And so in the top, it shows you the different types of contraceptions. And then it talks about certain considerations that you would think about in patients with liver disease. So for the combined that contain estrogen, you would worry about high blood pressure, blood clots, strokes. For the progesterone only pill, there's like a theoretical risk of conversion of high dose progestins, but uncommon. Down here, this is a table showing how the AASLD and the CDC medical eligibility criteria agree and disagree. And so the first side is the CDC, and then the second side is the AASLD. And overall, and I guess I would say this is the 2016 guidelines. The next slide is the 2024 guidelines from the CDC. But again, compensated cirrhosis, generally everything is acceptable. Decompensated is where there's a little bit more pause. However, like the CDC initially said, even a progesterone IUD, maybe the risks would outweigh the benefits, but the AASLD thought that was okay. Here's the medical eligibility criteria of 2024 from the CDC. Overall, it's liberalized. And so, for example, the progesterone IUD went from a 3 to a 2. So it's a little bit more accepted. Again, if they're compensated, pretty much anything is okay, but decompensated, you should think a little bit harder about and avoid the estrogen. They also, we won't speak much about it here, but they have a section on liver tumors and the birth control that you can use in that setting as well. Now we'll jump into acute and chronic liver diseases that can co-occur in pregnancy. And we'll start with hepatitis C. I think, generally speaking, now the recommendation is to test every pregnant patient for hepatitis C as part of their prenatal labs. That's changed from in the past when it was just people who had risk factors. This picture is from UW, so you test with the hep C antibody. If it's negative, then you can stop, unless of course they're at risk, and in a window period, you would maybe want to check an RNA. But if their antibody is positive, then you move to the viral load or the RNA. Not detected. They don't have a current hep C infection. And then if they have a positive antibody, positive viral load, then they have acute hepatitis C viremia. The risk factors for vertical transmission are hepatitis C viremia, and patients who have a positive viral load, it's about 6 to 7% that end up transmitting. There's increased risk if the patient has co-infection with HIV, if they're actively using IV drugs, or any intrapartum fluid exchange. And I would say ideally, you would treat the hepatitis prior to pregnancy, but that's not always the case. If they test positive for hepatitis C, you'll want to get these initial labs, CBC, CMP, coags, viral load, like I said, a genotype, and then you'll want to test for other STIs. You can get the hepatitis A and B titers, and then you can vaccinate them if they are not immune to help protect them. And then a little out of our wheelhouse, but they overall, if the pregnant patient needed an amniocentesis, it's thought to be fairly low risk. Overall, there's not any antivirals that are approved in pregnancy. You could potentially treat on a case-by-case basis per the guidelines, and then just avoiding ribavirin because it is teratogenic. For intrapartum and postpartum, for delivery, hepatitis C alone is not an indication for C-section, so you would just have the usual obstetric indications for C-section. And then the other things to keep in mind is avoiding any mixing of maternal and fetal blood. So avoiding rupture of membranes longer than 6 hours, avoiding internals, but specifically an FSE, and then even an episiotomy is listed as something to try to avoid. Breastfeeding is thought to be okay or not recommended against because overall there's low transmission rates. But if the mom has cracked bleeding nipples, then they should hold off breastfeeding at that time. Here is just a figure of the CDC guidance on when to treat or when to test the infant. You can test a viral load at 2 months and 6 months. If for some reason that was missed, you can still test a viral load at 7 to 17 months if they haven't previously been tested. And then 18 months and older, you could just get the anti-Hep C antibody to test the child that was exposed in utero. Next, we'll talk about non-alcoholic fatty liver disease. Overall, pregnancy is an insulin-resistant state, so is NAFLD. I think the current data says that 10% of reproductive age females have NAFLD. This is from a meta-analysis in 2021 looking at the adverse fetal and maternal outcomes of NAFLD. And so if you see right here, the odds ratio of having GDM is 3.23, preeclampsia 3.24 for maternal outcomes. For fetal outcomes, the odds ratio premature birth is 2.02, an LGA baby 2.01. And so it is associated with complications for the fetus and the mother. And it's often associated with other kind of metabolic dysfunction, obesity, diabetes, hypertension. There's not a lot, there are no guidelines currently on the management of NAFLD in pregnancy, but probably not surprisingly, the goal would be to optimize any metabolic conditions of the mother prior to the pregnancy, so specifically with lifestyle and dietary modifications. And then after pregnancy, the recommendation is breastfeeding. It decreases the risk of complications in the mother, and then it actually decreases the rates of the infant of having NAFLD themselves in the future. After that, we'll talk about cirrhosis. Cirrhosis is pretty high risk if a patient with cirrhosis were to become pregnant. The maternal risks, there's a 15% risk of decompensated cirrhosis, 11% risk of ascites, and 5% risk of variceal hemorrhage. I put the stars here just because the mortality associated with cirrhosis is generally from variceal hemorrhage and bleeding. And it would be good to do a MELD score before they get pregnant. And if it's greater than 10, which I generally think of as like not super impressive or high, it's associated with 83% sensitivity and specificity for hepatic decompensation. In terms of obstetric risks and fetal risks, there's an increased risk of preterm delivery, need for C-section, SGA, infant, and preeclampsia associated with cirrhosis. Again, variceal management has a high kind of morbidity and mortality in pregnant patients with cirrhosis. Before they become pregnant, the recommendation is to get a screening endoscopy within 1 year prior to conception. And then if you look at this figure, it kind of tells you what to do. So if you do get it within the 1 year prior to conception and they don't have varices, you're good to go. If they have small varices less than 5 millimeters, you could initiate primary prophylaxis. And we prefer carvedilol or propranolol. And then if they have large, then you could do the non-selective beta blocker or the ligation. If you're on the other side and the patient did not get a screening endoscopy prior to pregnancy, the recommendation is that they get it in the 2nd trimester. And then the interventions are the same. Beta blocker if small varices, and then ligation if medium or large. If the patient comes in bleeding, you can use octreotide and somatostatin like we would use if they were not pregnant. And then you would want to avoid terlipressin just because that can cause contractions. Considerations for delivery for patients with cirrhosis is that you would want to aim for a short 2nd stage of a vaginal delivery. So you could use a vacuum or forceps, but just trying to avoid Valsalva, especially if they have known varices, because that can exacerbate them. You want to prepare for bleeding. And then the other thing that I didn't realize is just thinking about hepatic dosing of medications that are hepatically metabolized, for example, Cytotec. Okay, we made it through a few of the diseases that co-occur in pregnancy, and that was just, a few. There are so many, and there are guidelines about the others. But now we'll move into gestational liver disease, and we'll start with preeclampsia and hypertensive disorders of pregnancy. Just a reminder, so I like to think of them as a spectrum, and ask myself if the elevated blood pressure starts before 20 weeks or after 20 weeks. We define elevated blood pressure as 140/90 on 2 separate occasions, separated by 4 hours or more. If it happens before 20 weeks, it's likely a chronic hypertension, which we won't spend much time talking about. After you ask yourself about when it starts, ask about protein in the urine. If they don't have protein in the urine, that's gestational hypertension. If they do have protein in the urine, that's preeclampsia. And then finally, you can ask yourself about if they have any severe features, which we'll talk about a little bit more on the next slide. And again, kind of spectrum, HELLP syndrome is kind of worse on the spectrum, eclampsia or seizures also on the spectrum of the hypertensive disorders of pregnancy. Severe features, blood pressure, systolic blood pressure greater than 160 or diastolic greater than 110 on 2 separate occasions, separated by 4 hours or more. If you're treating with an antihypertensive, you don't have to wait the 4 hours to make that diagnosis. Other things, thrombocytopenia less than 100, LFTs twice the upper limit of normal or persistent for quadrant pain, evidence of renal insufficiency, so creatinine greater than 1.1, or if they double their normal creatinine, pulmonary edema, visual disturbances, or persistent headache that's not responsive to medicines. For antepartum management, you would start this when the diagnosis is made. So on the left side of the screen, we have without severe features. So, and that is preeclampsia without severe features or gestational hypertension. And you can take care of them outpatient with close monitoring. For monitoring the fetus, you'll want to do a growth ultrasound every 3 to 4 weeks, an NST once to twice weekly, and a weekly AFI. For the mom, you'll want twice weekly labs looking for evidence of those severe features, and then close blood pressure monitoring. If they have any of the severe features or eclampsia or HELP syndrome, that is criteria for admitting them, and they should remain in the hospital until they deliver. For the fetus, you'll want to give them steroids if they're less than 34 weeks. For lung maturation, give them MAG for neuroprotection if they're less than 32 weeks. And then for the mom, giving them MAG for seizure prophylaxis. Often, and I think a lot of MFMs we work with do it differently, but if they're not going to deliver them right away, you start it when they're admitted, and then you can stop it. Some do 12 hours, some do through the steroid window. But then I think an important thing is once you decide to move towards delivery, restarting the MAG and continuing for 24 hours postpartum. The other aspect of maternal care is blood pressure control, with labetalol, hydralazine, or nifedipine being first line. Delivery consideration. So timing of delivery, if you have no severe features, you can deliver at 37 weeks. If you have pre-E with severe features, you deliver at 34 weeks would be the goal, unless you have maternal or fetal deterioration. I think, when thinking about this, we are also in close contact with our obstetric call, and with a lot of these disorders, medicine is a team sport, and we are in close contact with our obstetric and MFM colleagues, as well as other people that we need to help manage these conditions. These tables right here would be indications to deliver someone sooner than 34 weeks. So if, eating through antihypertensives, you can't control their blood pressures, their headache is unrelenting, stroke, MI, HELP syndrome, if the fetal testing is non-reassuring, those would all be kind of reasons to deliver sooner. HELP syndrome, you would want to expedite delivery kind of regardless of gestational age, and same with eclampsia. Again, they can deliver vaginally. You can have, and the C-section would be for kind of the usual indications. But I think I read a statistic that they're like 97% likely to have a C-section if they're less than 28 weeks. The best way we have right now of preventing preeclampsia and the hypertensive disorder of pregnancy is is by use of a baby aspirin, 81 milligrams daily. If the patient has high risk factors, history of preeclampsia, diabetes, chronic hypertension, any of these, they only need one of those to start it. And then otherwise it's 2 moderate risk factors. Obesity, family history of preeclampsia, low socioeconomic status, advanced maternal age. But I think generally speaking, a lot of patients meet criteria for this. The recommendation is starting it before like 16 weeks, and we often start at 13 in our clinic. I just wanted to take a minute to talk about social determinants of health. Specifically, I'll talk about preeclampsia, hypertensive disorders of pregnancy, and about the Black and Hispanic population, but want to call out that kind of the ideas and themes span obstetric care, and they affect many other populations as well. This was just what I chose to focus on for this presentation. 2/3 of Black people with preeclampsia are diagnosed and have severe symptoms or severe features versus less than 0.5% of the white counterparts. Your risk of dying of preeclampsia, eclampsia is 5 times greater for Black individuals. And then Black and Hispanic patients have twice the risk of stroke in association with hypertensive disorders of pregnancy compared to their white counterparts. There's a lot of different reasons for this. There is, institutional racism, there's chronic stress, and the thought is that can change their HPA access, and so they probably at baseline have higher rates of GDM, hypertension. Also, having reduced access to healthcare would lead to less preconception counseling or optimization of their other chronic health problems that can pose higher risks in pregnancy as well. Here are some potential interventions. This was partially from me, partially from the Preeclampsia Foundation, which in 2020 created a group to try to combat some of these problems. First is just acknowledging and kind of trying to dismantle systemic racism and interpersonal racism. They talked also about representation in medicine and having doctors that look like you and have shared lived experiences with you can improve outcomes. Working on educational programs for patients, thinking about screening early and considering aspirin in your pregnant patients. And again, like not a ton of people have the high risk, but a lot of people meet criteria for 2 of the moderate risk factors. Something that was interesting to me was the postpartum follow-up. I read a study that I think 50% of Black patients were lost to follow-up in the postpartum period, even if they had pre-E with severe features. And so kind of working on trying to kind of capture people and provide them closer blood pressure monitoring and postpartum care as well. And then just continuing to do research on all of these social determinants of health and health disparities. Next is intrahepatic cholestasis of pregnancy. So things that you would look for is in pregnancy, if the pregnant patient has itching, especially on their palms and their soles of their feet, not associated with a rash, then you would worry about cholestasis of pregnancy. You diagnose it by getting bile acids, and then often you will get a CMP as well, which can have elevated LFTs and can have elevated bilirubin, but that's not needed for diagnosis. Like all things in medicine, you want to make sure that the reason of their itching is from cholestasis rather than an assortment of other causes that could cause itching in pregnancy. Here are some risk factors for cholestasis. I think a really big one is having a family history or a personal history of cholestasis. And then right here, this helps delineate cholestasis by their bile acid level, and it kind of determines their risk as well as the goal timing of delivery. So 10 to 39 is pretty low risk. Usually, not always, the babies do okay. And then delivery timing would be 37 to 39 weeks. SMFM says anywhere from 36 to 39 weeks. Bile acids 40 to 99 is a little bit more moderate. There's risks of preterm labor, meconium, aspiration. And then again, that's kind of our range, 36 to 39 weeks delivery. And then greater than 100 of bile acids is severe. The thing you worry about is stillbirth. And that can be 35 to 36 week time for delivery. SMFM recommends 36 weeks, I believe. For management, for medication, you can give them ursodiol. There's a lot of mixed evidence. So it can help with the itching. Some studies say that it doesn't help with any neonatal outcomes of stillbirth, etc. Other studies say maybe it helps if the bile acids are greater than 40. So it's a little inconclusive. Second line treatments would be rifampin, cholestyramine. And then for antenatal monitoring, you would do an NST 1 to 2 times weekly, but it's not really shown to prevent stillbirth because we think that it's a sudden event that causes death of the fetus, either a cardiac arrhythmia or an acute event with the placenta. And so NSTs can't predict that in the same way that they can predict the kind of chronic placental insufficiency seen with like preeclampsia or something like that. For delivery, ICP differs a little bit from others in terms of when to give steroids. And so the recommendation from maternal fetal medicine is giving steroids if they're less than 37 weeks. My guess would be because of the pulmonary effects. And then these are reasons to consider even an earlier delivery between 34 to 36 weeks. So unrelenting pruritus that's not relieved by meds. If they have a history of prior stillbirth less than 36 weeks due to cholestasis, and then they have recurrent cholestasis, or if they have any pre-existing liver disease with worsening liver function. Okay. Our last gestational disorder is acute fatty liver of pregnancy. I've never seen this. I hope to never see it, but I think having it on your differential and knowing about it will make it so that you think about it and don't miss it, because early detection is really important, especially in this one. I think of this like just acute liver failure of pregnancy. The most studied risk factor for the mom getting this is that the fetus has LCH-AD or other fetal fatty acid deficits. And so essentially pregnancy in general causes an increase of the fatty acids, and then the fetus will have a defect and be unable to metabolize, and then it will build up in the fetal and also in the maternal systems, leading to these symptoms. We'll talk about diagnosis on the next slide, but again, this can be scary. It can lead to acute liver failure and the need for a transplant, ICU admission, etc. The clinical symptoms are a little bit, can be vague. Nausea, epigastric pain. More obvious ones would be jaundice, encephalopathy. Everything I was reading was talking about, plus or minus hypertension, but you want to differentiate this from the more common HELP syndrome or other kind of pregnancy disorders. The Swansea is a kind of helpful diagnostic tool. And so it's more likely if you have 6 or more of the following of these. I'll point out again, encephalopathy, bilirubin greater than 14. If you have someone who's hypoglycemic, I would think about this. Getting uric acid and ammonia levels can be helpful. You can get a right upper quadrant ultrasound. Sometimes it shows a bright liver, but sometimes it doesn't. And then you would know for certain if you had a biopsy, but generally care is not postponed for biopsy results. You would just proceed with delivery. Management is delivery of the fetus, and then it's largely supportive care and time, and then having a big team to kind of help with the ICU care, the anesthesia care. Here, again, this is about management. The most important thing is delivering the fetus. There's kind of mixed evidence on C-section versus vaginal delivery. A C-section is faster, but it's associated with higher rates of intra-abdominal hemorrhage. But a vaginal delivery, especially if they were earlier on, could potentially take longer. There's a lot of hematologic complications, thrombocytopenia, hemorrhage, DIC. Renal complications can range from an AKI to full-blown hepatorenal syndrome with a need for dialysis, plasma exchange. Their liver, they could have acute liver failure. They could also have encephalopathy leading to coma or requiring intubation. They can get infected and need antibiotics. So I don't know. In my medicine type brain, I think of a lot of things related to complications of cirrhosis in a non-pregnant person you would also be dealing with in this situation. You would want them to be at a tertiary care center. So if you're rural, shipping them there with a multidisciplinary team, again, sometimes needing a liver transplant or being in the ICU. But interestingly, if they survive, the long-term outcomes are quite good. So delivery, often they get clinically better within 3 to 4 days of delivery, and then their labs follow within a week or 2. And a study showed that most patients who have this happen don't have any long-term liver sequelae after they recover. And then here is a summary slide. This is from FIGO, and so just going through it, the white section is pre-existing liver disorders. This gray section on the bottom is gestational liver disorders, and then it summarizes delivery timing. They can all have spinal or epidural, assuming that their platelets are not too low. It talks about vaginal delivery considerations, so short second stage and cirrhosis. It talks about C-section precautions, again, like being ready for a hemorrhage in a patient with cirrhosis and thinking about varices, kind of similar for acute fatty liver, and then also some postpartum care and for acute fatty liver, that it can get worse and then better, and then for cholestasis, just following to make sure their labs normalize. let's see, here we are, part of a team. Medicine, like I said, is a team sport. And so, you know, depending on the clinical situation and the severity of situation, we may be in contact with these other team members. And yeah, hopefully this was helpful, whether you are doing zero obstetric care to whether you are FMOB in a rural area. And then here's my dog, which I always like to end my presentations with. Does anyone have any questions?
What a cute doggy. What is your dog's name?
This is Mackie.
Hi, Mackie. Good boy. Good girl? Good boy.
Good girl.
Good girl. Any questions? Feel free to put them in the chat or unmute yourself to ask Dr. Phelps any questions you have.
Hey, Dr. Phelps, this is Katie Myers. I was wondering with Hep C vertical transmission, does it matter? Like, is there a dose related, like how high their viral load is? Is it higher chance of transmission?
Yes, the higher the viral load, the higher chance of transmission. But that being said, even if they have a detectable viral load, the rate is like 6 to 7% of it being transmitted to the fetus.
Any other questions? Feel free to unmute or put them in the chat.
Hi, this is Robin Sauter up in Moscow, Idaho. I have a brief question just regarding aspirin dosing and if you guys are, or in your reading about this presentation, reading anything about higher doses of aspirin in use for those that are even higher risk for preeclampsia.
Sure. I think the current recommendation is 81 milligrams. In preparation for prior presentations, I've read studies about like the 81 versus 162. But I don't think the people like the MFMs that we are working with are starting to use higher doses quite yet.
Great. That's kind of what I think I've run into too, is where there's some information, maybe, but not enough literature yet. So good to know what you guys are doing down south. Thanks.
Dr. Tubbs put in the chat that this was good, understandable for one who isn't active in maternal fetal medicine. So some feedback about how helpful this was. Any other questions, please unmute or put them in the chat. Okay. Well, thank you everyone for being here today. Thank you, Dr. Phelps, for a great presentation.
Sorry, I have one more question really quickly, if it's okay. Hi, Dr. Phelps, this is Alexis. We had a question over here of at what point in pregnancy acute liver disease will occur or acute fatty liver of pregnancy will occur? Like, is there a specific gestational age in which
It's
you're monitoring that?
generally the second to third trimester is when it occurs. And then there were some studies that talked about, I don't know why you would be worried enough to do this, but that you could check early on by testing the fetus for the fatty acid disorders. But to me, it seems like it's so rare. I don't know what would possess you. Maybe if the mom also had a fatty acid disorder or something like that. But generally second to third trimester.
Any other questions? All right. Dr. Phelps, thank you so much. Just so everybody knows, there will be a recording of this presentation. If you go to the publications page of the IAFP website, there is a CME library link. We'll get this posted in the next month. That won't be for CME credit, but if you want to review the content of today's presentation, and we also got some more feedback that this was a great presentation. Fantastic work, Dr. Phelps, from the R3s in Winslow. So applause to you. And while I was working in the background, it occurred to me to share that the AAFP, and I'm dropping this in the chat now, is offering, I just saw, it looks like a kind of a conference on family-centered pregnancy care in Denver at the end of August. And I thought some of you might be interested in that. So hopefully that link takes you to that information if you wanted more of this, topic area on some level. And I'll be putting that in e-news upcoming as well for people who are interested. Please make sure to fill out the Google form if you want to see me, or email me. I will be sending certificates in the next month or so. And our next CME will be with Full Circle Health Nampa on July 14th with a topic to be determined. And yeah, Dr. Davids is endorsing the AAFP CME that I just shared there. So hopefully that will be of interest to you all. And Dr. Phelps, is there anything else you'd like to share?
I don't think so. Thank you for coming.
Yeah, have a wonderful vacation and congratulations on completing your program and moving into your fellowship. That's super exciting.
Yay. Thank you. Bye-bye.
Everyone.